And you can start, Tamar. Thank you very much for talking to us.
Okay, thank you very much for inviting me. It's a great honor for me to be here. So the topic of our talk will be disorders of consciousness, insights from using neuroimaging. So we'll talk first about the terminology of DOC very briefly, and then our talk will divide to two parts: the current approach of disorders of consciousness assessment, which includes the clinical assessment and the neuroimaging evolution. And the second part, I will talk about studies in our lab. So the questions of the meaning of consciousness is probably one of the mysterious and complicated questions about the phenomena of the human being. And here's the citation of Einstein that said the following: a human being is a part of the whole called by us universe, a part limited in time and space. He experiences himself, his thoughts and feelings as something separate from the rest, a kind of optical delusion of his consciousness. So these phenomena have been widely explored along the years in many terms, in many fields like philosophy and cognitive neuroscience, but I'm going to focus today on a specific, maybe more practical aspect of it, of what happened when a person actually loses the basic components of consciousness, the basic expression of his consciousness as a result of acquired brain injury. So this group of disorders is coined disorders of consciousness that, as I said, may occur after a severe brain injury. The most common etiology is traumatic brain injury, but it could also be anoxic brain damage, for example, after cardiac arrest or asphyxia, difficulties with breathing, or for less extent, even very widespread stroke. So this group of disorders essentially contain three conditions. The first is coma. The second is what we called in the past vegetative stage, or in the more updated term, unresponsive wakefulness syndrome. And the third one is the minimal conscious state. And I'm going to briefly describe each one of them. So coma is a state that the patient with continuously his eyes is continuously closed, despite repetitive attempts to allow them, they don't respond in any way. There is complete unresponsiveness, and it's usually an acute phase. It's usually up to 4 weeks. And the second condition is unresponsive wakefulness syndrome, or vegetative state. In Hebrew, we call it many times tzemach. In this stage, the patient has sleep-wake cycle, meaning he has alternating hours of opening his eyes and closing his eyes, but still there are any signs of awareness. There is partial or complete preservation of hypothalamic and brainstem autonomic functions, meaning in this condition, usually they are not dependent anymore on ventilation machine, for example. We can see some reflexive behavior. Their essential signs are normal, like their blood pressure is stable, and etc. But again, there is no any signs of conscious awareness. And minimal conscious state, except for the sleep-wake cycle that we have also in the vegetative state, there are minimal signs of awareness of self and surrounding. But these signs are inconsistent, meaning I can come, for example, to a patient in the morning and call his name and maybe see a kind of response, or his move, or his head can move forward me. But when I come again in the evening, maybe I cannot get that response. So from one end, it is inconsistent, but it's reproducible, meaning I can see it more than one time. And there is also subclassification to minimal conscious state minus, in which the patient had only visual fixation and pursuit. and minimal conscious plus when the patient have also communicative capabilities. He can show signs of language understandings. For example, he can move any part of his body to command. And we're saying that the patient emerged from minimal conscious state if he fulfilled one of the two criteria. The first is meaningful object use, and the second one is consistent communication. So if we want to systemize this, we can look at this context of consciousness as based on two cardinal components. The first is wakefulness, which is the level of consciousness, and the second is awareness, which is actually the content of consciousness. So coma will be at the lower part in the two axes when the patient is like wakefulness and awareness, and awake, conscious, healthy person will be intact in both of them. In vegetative state, there is wakefulness, but without awareness, and in minimal consciousness state, it's also have a wakefulness, but in higher level of awareness. So how is the clinical diagnosis made now that we understand what each condition mean? In the clinical setting, we have the behavioral assessment, and what's considered as gold standard is the most validated and commonly used scale, which called coma recovery scale revised. And that's how this scale looks like. It's divided to 6 subscales: the auditory function, visual function, motor or motor function, communication, and arousal, in attempt to find any sign from any kind of response. It takes about 30 to 45 minutes to conduct this assessment, and it has very accurate instruction of how to execute this scale. For example, in the visual function, we get a mirror and put it in front of the patient and see if he fixates on the mirror and follow while we are moving it to the different sides. So we have some main challenges of disorders of consciousness patients assessment. The first one is that this is actually indirect measurement. If you think about it, almost on all other situations, we can ask the patient, what does he feel? Does he see? Does he hear us? And etc. And in this situation, we have no any communication with the patients. We can just guess from what we see that he does. And another thing that we have to remember in this patient that there are severe brain injured, and like in other patients with severe brain injury, this might be sensory and perceptual impairments. For example, it can be impairments in the auditory system or the visual system, so or language system, for example, and maybe the patient cannot understand what we say, or cannot see or hear us. And not only the bottom up system can be injured, but also what we call the output system, the bottom down, the initiation, the motor planning and motor executing systems can be injured in these patients. So as a result of these challenges, we know the signs of consciousness are missed in about 40% of patients, which is quite a large proportion of the patients, meaning we mistakenly diagnose patients as vegetative state, although they are minimal conscious in about 40%. And we call this group of patients as belong to cognitive motor dissociation. And again, if you want to look at it schematically, we have here two axes. Pay attention that here the axes are different from the former axis, there is the motor function and the cognitive function. And when we are saying motor function, we actually mean any behavioral function. In coma, we have no motor function and cognitive function. And for recovery, both of them are intact. In vegetative state and minimal conscious state, both of these functions are a little in higher level. And here we can see the patient that their motor function is very low, but their cognitive function might be in higher level. And the question that raised up is why this is so important for us? What's the importance of accurate classification? So we have some very critical reasons. The first is that it has a very important prognostic value. A patient in minimal conscious state have much higher chances to resolve to conscious state. And as a result from that, we have also meaning for caretaking strategies, like the decision if the patient will go to a rehabilitation unit or to a nursing facility. And also specific treatments like some kind of direct stimulation that will fit to one condition, not to another one. There is also great impact on ethical issues. It's less relevant here in Israel, but abroad, for example, in the United States, it can affect very difficult decisions about continuing or withdrawal from life-sustaining therapy. And the last one, maybe the most important, I think, as a caregiver of such patients, you know that it has a great emotional impact and quality of life also for the patient. If you think about the patient that understand and aware of his surrounding, but his surrounding doesn't aware that he understand. And also for the families, we know that maybe the most important thing that family want to know is whether their loved ones can hear them, if he understand, if he feel pain or other feelings. And it's very important to us to give them the opportunity to know the exact state of the patients. And I brought here a very short segment of a movie that had been done about a patient that was hospitalized in our unit after a severe traumatic brain injury. And he went through all the stages from coma to emergence from a minimal conscious state. Just to give you the feeling of the experience that the family have in this situation and why this is so important to us to know the accurate diagnosis.
אתה זוכר את הפעם הראשונה שראית את אבא כשהוא פצוע?
כן, אני זוכר. הוא לא הצליח לפתוח את העיניים.
זה היה מפחיד?
לא, זה היה טוב. חשבתי שהוא נשאר כמו שהוא היה לפני שהוא נפצע בלב, ובחוץ הצעה שלו השתנתה.
מתי הוא מתחיל להתעורר?
אחרי הרבה חודשים.
נדב, אתה שומע אותי? נדב, תפתח את העיניים.
זה לא התעוררות כמו בסרטים. אני תמיד דמיינתי שהוא יתעורר, והייתה את ההיסטריה הזו של איך אני לא אהיה לידו, כי אם הוא פתאום יתעורר, אז זהו, שהם לא מתעוררים פתאום. זה רק בסרטים.
נדב, תרים את האצבע. יופי, נדב! תרים עוד פעם את האצבע. יופי, נדב! כל הכבוד לך. נדב, כל הכבוד לך. אתה שומע אותי, נכון? אתה שומע אותי? אם אתה שומע אותי, תרים את האצבע.
Okay, so our major challenge is to improve the precision of the clinical assessment of disorders of consciousness patients. And the question is how we're doing that. Then we have the neuroimaging revolution. In the last about 2.5 decades, thanks to the modern technology and the development of the research in this field, we could actually capture neural correlates of cognitive processing that give us information that we couldn't imagine to have just from the behavioral assessment. So in this field, we have mainly the cognitive task-based paradigms, which consisted of the passive paradigms, the active task paradigms, as naturalistic paradigms. And there is another direction of resting states, which we have also research in this direction in our lab, which captured the spontaneous activity of such patients, but we'll not cover it in this talk. It deserves a separate talk. So I will give a short example of each one of them. In the passive paradigms, for example, here is a study of a vegetative state 20-year-old student after hypoxic ischemic brain injury. This is a passive visual paradigms. She was shown simple flashing checkerboards while she was under the fMRI scanner, and we can see activation in the primary visual cortex. After that, she has been shown familiar and unfamiliar faces, and we can see activation in the fusiform face area. And when she was shown landscape scenes, we can see activations in the parahippocampal place area. So the pros and cons of the passive paradigms. The main pro is that it gives us evidence of cognitive processing without observable behavioral manifestation. As we said, it's very exciting and a novel way to assess these patients. And the main con is that this way may not represent high-level cognitive capacity and consciousness actually, especially when sensory regions are tested. Because as we know, for example, the fusiform face area can be activated without any conscious awareness. We have also in our lab a study of that Noam running now with fMRI using masking technique and show movies of faces, and she got activation in the fusiform face area, while we know for sure that the participants are not aware of what they see. And then comes the active task paradigm. So this is one of the first and most famous study in this field. This was pioneered by Adrian Owen, which is one of the prominent researchers in the field of disorders of consciousness. And he said, okay, if the patient cannot execute the task, maybe we'll ask him to imagine he's doing the task. So he developed a paradigm with imagination task. The first task was imagine you are playing tennis, and the second task was imagine you are moving from room to room in your house. And what they saw, we can see in the control group in the tennis imagery task, they saw activation in the supplementary motor area, and in the special navigation imagery, they saw activation in the hippocampal place area, as well as the posterior parietal cortex and premotor cortex. And also in vegetative state, they had a patient that was vegetative for about 20 years. And for their surprise, they saw a very similar activation in the tennis imagery task. They saw activation in the supplementary motor area. And in the special navigation imagery task, they saw activation also in the parahippocampal place area and other areas. Just to mention that several years after that, in 2010, they published another study with this paradigm with a larger cohort, and also they tried to take it to the direction of BCI, meaning they asked the patient a question with a known answer, like is the name of your father is Alexander? If the answer is yes, please imagine you are playing tennis. And if no, imagine you are walking around your house. And they got very positive results. So the pros and cons of this active task. The main pro is that it's actually represent willful modulation of brain activity, and thus it must reflect intact high-level processing and likely consciousness. But the main con here that it's likely requires too much effort. You can think about it that the patient, in order to succeed to activate this region, he needs to understand the task and to remember it and to imagine that he actually executes the task. And this leads to the fact that it might not be sensitive enough. And actually we're back into our primary problem that we might miss consciousness signs in some of vegetative state patients. That's just because it's difficult for them because of other disabilities. And the third paradigm in this part is naturalistic paradigm. And naturalistic paradigm is, in naturalistic paradigm, the brain activity is measured while the participant is passively exposed to a stimuli of naturalistic character, like movie, story, or any other narrative. And the pioneered work with this paradigm was of Uri Hassan and Rafi Malach. They've shown movies for participant while there was in the fMRI scan, and they showed activation in specific areas that was common in group of subjects while there was shown these movies. And recently this paradigm was adopted in the field of disorders of consciousness, while the idea is that if a person is able to follow the plot, we can infer that he is consciously aware. So in this way, we can detect awareness without complicated active commands. And this is again a study that been done by Adrian Owen with Louis Nanachi. They used a movie, a very suspenseful movie of Hitchcock, while the patients were scanned by fMRI. And we'll talk later about how we analyze this information when we're talking about studies in our lab, because we also have a study with naturalistic stimuli. So some fMRI imaging consideration, because many of the studies in this field use the modality of fMRI. We have to remember this, from one hand, this method is relatively with very high sensitivity, but from the other hand, it has also some important cons, because it's relatively complicated for patients study. If you think about it, the mobility of these patients is very uneasy. There are many times with tracheostomy, with feeding tubes and other devices, and it's very difficult to mobilize them. fMRI is not everywhere accessible, especially in rehabilitation units. And it's also unlikely will be used more than one per patient. And we know that we are interested in a tool that we can also follow the state of the patient, not every day, but every few days or weeks. And a few words about neuroimaging of disorders of consciousness patients in Israel. So historically, this is undeveloped field. You can see that there are just counting numbers of studies in this field from Israel compared to other centers like in Canada, United States, and also states in Europe. And there is also no routine clinical use. Again, there are centers, for example, in Paris, that EEG assessment of these patients is a part of the routine assessment in disorders of consciousness. So actually, that was my main motivation to come into this field and try to advance it and connect the neuroscience aspect to the clinical attitude, and at the end bring the best care that we can to our patients. So to sum up what we've talked till now, we said that determining the consciousness state of severely brain damaged patients has a critical consequences. We thought that there is an inherent difficulty in classifying level of conscious awareness in individuals who cannot report their self-experiences. And we saw that adapting neuroimaging techniques to the traditional behavioral assessment revolutionized the field. But as we could see, there is no one ideal way of imaging, and new and more efficient paradigms are needed. So now I'm going to talk about studies in our lab. So when we come to develop new paradigms for disorders of consciousness patients assessment, we have some criteria that we want to take into account. First, as we talk, we want it to be applicable at bedside and not fMRI. For example, we wanted to test high-level cognitive functions because, as we saw, we want to be sure that we can infer that there is high cognitive processing, that there is an indication of consciousness and not just sensory intact systems. And we also want it to be not a thoughtful, we want it to be enough sensitive paradigm. So our approach, we used functional infrared spectroscopy, FNIRS, which I will show you in a minute. With that, we imaged the frontal lobes that, as we know, are known to be involved in high cognitive processing. And we used simple sounds and naturalistic stimuli, which are not thoughtful, passive stimuli. So fNIRS imaging, here is a subject that participated in our study. Some basic points, we can see that the optoids are on the prefrontal area. We have 4 emitters and 1 receiver each side, what gives us 4 channels from the right and 4 channels from the left, and the sampling rate was 10 Hertz. And just the basic principle of fNIRS, we have a light emitter and light detector, and we get a signal very similar to both signal of fMRI that actually express the oxyhemoglobin level. So our paradigms are divided into passive paradigms, which include the experiment 1.1 with semantic sounds and experiment 1.2 with familiar and unfamiliar sounds. And the second is naturalistic paradigm. In experiment 2, we used auditory story and music. And we used all these 3 experiments as a battery with the same patients that we could induce that if patients succeed to show activity similar to the healthy in all of these 3, his cognitive level is higher than if he show a similar activity only in 2, 1, or none at all of them. So the logic of our paradigms, we develop the paradigms with healthy participants, and that's the results that you're going to see today. In this paradigm, we compare 2 conditions, for example, meaningful versus non-meaningful sounds. And sensitive paradigm will be if we find difference at neural level for most healthy participants. And at the end, the bottom line, we will then check whether we find similar effects as we find in the healthy participants for the disorders of consciousness patients. So in experiment 1.1 with semantic sound, it was a study, it's block design, and block duration was 50 minutes. We had 24 meaningful and 24 scrambled sounds. It was passive listening without any active task, and we had 21 healthy participants. And the result, as we can see, here we have in y-axis the average oxy levels. Here we see the two conditions, and every dot here is a participant. We can see in the group level very robust effects. The average oxy levels was higher in noise compared to the semantic sounds, and we can see it in all of the 8 channels. And also, actually, we are interested in individual level because at the end we want to use it to individual patients and conclude about their cognitive level, as we said. So we saw about 75% of the subjects show this effect. And experiment 1.2, we used familiar and unfamiliar songs. Here again, it was block design with block duration of 20 seconds. We had 27 familiar Israeli songs and 27 unfamiliar Israeli songs. And we knew that there actually was familiar and unfamiliar because after that we asked the participant with questionnaires, they knew the songs or not. And we had 23 healthy participants. So here again, the average oxy levels across the blocks and the two conditions of familiar and unfamiliar songs. And we can see at the group level very robust effects in all channels. And also in individual level, about 80% of the subjects showed these effects. Now the naturalistic stimuli paradigm. We used 4 auditory parts of about 9 minutes each. We used a short story of O. Henry, which called Vegetative, and Scrambled Story. And we used another story because we didn't want the participants to recognize the story. And the other pair was the classical music of Tchaikovsky and Rachmaninoff and face scrambling of this music. So our prediction for the healthy participants are that the people need, as we said, consciousness to follow the story. And subjects will have similar brain activity when listening to intact story, because again, they have the same experience, the same cognitive processes. But we expect to see no similarity or smaller similarity when they will listen to Scrambled Story. And we can see here example of raw data. This is one channel in one condition, and each colorful trace here is a subject. So it's quite messy, but we can see some ups and downs, some trends here, and we need a way to analyze it. So the way we analyze usually naturalistic stimuli is by intersubject correlation, and here we use leave one out intersubject correlation. In this method, we take, you can see here in the example, we take all the traces of the patient except for one participants except for one participant. It's n-1 subjects. Every colorful trace here is a time course of participants, and the bold black trace is the average of all the participants except for one subject again. And this is a trace of the subjects that we get out, and then we compute their correlation, Pearson or Spearman correlation between them, between the average of all of the participants and the one that we get out. And we repeat this procedure n times for every participant, and we get a correlation for every participant. And we calculate it in the two conditions, and then we compare the correlation between the two conditions. So we can see here the results. Just to make the story short, we can see these results in all of the channels. So we see here just the average. The correlation was much significantly higher in the story compared to the scrambled story in all of the channels. And also in individual level, we saw that approximately 75% of the subjects showed these effects. And in music versus scrambled music, in contrast, we actually can see that the results are much less robust. We can see other directions in different channels, and the result here was not reliable. Even the group level, we did see an effect in two occasional channels, two parallel channels from both sides, but we cannot say for sure what the meaning of these results. We were not sure that that they are reliable. So how we will use these paradigms with disorders of consciousness patients? So with the patients, we will not need to use the leave one out analysis. We just did it to resemble the way we analyze the data with the patients. We will use the average results of the healthy participants as a template, and disorders of consciousness patients with high level of consciousness will show similar to healthy subjects patterns of results, meaning the correlation for the story will be higher than the correlation for the scrambled story. So to sum up, we have developed a set of paradigms that have relatively high sensitivity. The paradigms will be used at bedside with DOC patients, and we plan to start testing patients soon. We've already obtained ethical approval for that. So I want to thank very much Dr. Vadim for all of his help, advising and guiding me on the research. And I want to thank Noam Somech and MSc students in our lab that helped me with running the EFNER study. And I want also to thank my colleagues from the Brain Injuries Rehabilitation Unit, Dr. Evgeny Gaidikov, the former head of the department, and the current head of the department, Dr. Alex Plavshitz, for their support and commitment to the research. And I want to thank very much the Gonda Center for the opportunity to enrich my knowledge and take part in this exciting brain research.
Thank you very much, Tamar. Very exciting talk, and I'm very impressed by your courage also to give a talk. You're the first student in the seminar, and hopefully we'll have more down the road. So this was really impressive.